Yay Networks.
Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady Rahban. And as always, we have a very exciting episode for you. I love doing the podcast. I love the educational content. I love hearing people write or say how useful this content is. And I obviously think that the content is even better when we have experts or patients or other individuals who can contribute. And today we have none other than my dear friend and amazing GYN surgeon, Dr. David Ghozland. And we're going to be tackling female genitalia rejuvenation. It's a mouthful because there's nothing sexy about it yet. But we're going to talk about all those areas of female private areas that can be enhanced, altered, changed, improved. And I had a segment on this before, but I was the one talking. Now I thought, well, what the hell? Let's bring in yet another expert. And Dave is definitely an expert. So welcome to the show, Dave.
Thank you, Dr. Rahban. I really appreciate it. It's an honor to be on your show.
So Dave, let's start out with you're in private practice, right? And you went in from a traditional GYN OB practice and gradually have kind of made this your area of specialty and expertise, right?
Yeah. So in 2005, actually, it's a funny story because one of our mutual friends is really, I'm going to give him credit to introducing me to the field, Dr. Gadir. In 2005, we all graduated together. We were all sort of developing ourselves as heaters. A friend of ours was doing his fellowship in reproductive endocrinology, and he came to me and said, David, I have a request. One of my chairmen wants me to write a committee opinion for our National Obstetrics and Gynecology Society on this new thing called vaginal rejuvenation. And I had sort of heard about it, but it was very out there in the galaxy somewhere. And I started doing some research, and there was just a couple people doing it, and I knew it. I felt it. I knew this was my future. So in 2005, I literally emptied my entire checking account and took this big course on vaginal rejuvenation and came back and realized that internet was really kind of absent. There was really no way of sort of doing this. And so it sort of stayed in my toolbox. I would do it here and there. And then maybe 2012, it started getting really popular, and it was really starting to overtake my practice. And in 2017, 18, I decided to make this almost entirely my entire practice. So I really specialize in sexual medicine and reconstructive surgery of the pelvis.
That sounded way better than the way I said it. I mean, you got to, there's a sexy way of saying things, and that was it. Say that one more time. What is it? What do you call it?
Well, listen, there's only a few things I say sexy, and I'm happy you think this is one of them. Pelvic reconstructive surgery is the term I use as a general catch-all phrase. Okay,
got you. So tell me what falls under that bucket. What are the because I want to do a little bit of a dive into each of these areas. And I address them in another episode, but you can never have enough conversation about this. So tell me what some of those subcategories are.
Yeah, so when you're talking about reconstructive surgery, so you were talking about surgery at this point, you're talking about vaginal tightening procedures, you're talking about labioplasty, both of the minora, the inner lips, and the majora, the outer lips. You're talking about clitoral hood contouring, so reconstructing the hood, maybe it's too broad, too wide. You're talking about non-surgical procedures such as laser treatments in the vagina. We were just talking about the fact that a huge part of my practice is platelet-rich plasma. And I use that in sexual medicine to improve orgasms, heightened sensation. And so what are we treating? We're really treating in vaginal rejuvenation. We're returning the ability to improve friction during intercourse for a lot of moms who've had childbirth or the aging process, so that they can feel more confident and actually feel better in the bedroom and achieve those orgasms like they used to. We improve urinary stress incontinence, which is a big part of pelvic surgery. And we improve aesthetically the appearance for a lot of women. That may be something that's a little bit uncomfortable in the bedroom or makes them feel insecure. So we do procedures in order to help them improve their confidence.
All right, great. So let's start with labioplasties. So the labia, obviously, for those of you who are familiar with the anatomy, is divided into the inner and outer lips, which we refer to as the minore and majore. The inner lips tend to be the ones that get kind of long and stretched out either just by genetics and or childbirth. And the outer ones are the ones that are the sort of the cushion or the bumper rails that tend to actually get more deflated than anything else. So let's talk about the labia, inner labia, or the traditional labioplasty. So there's it's becoming more and more popular. What do you do? And tell me your thoughts on the sort of your labioplasty thought process and approach.
Sure. So yes, labioplasty minora is a increasingly popular procedure because oftentimes if they are elongated, they can cause friction during intercourse and pooling, discomfort if they're wearing tight clothing or bathing suits. And aesthetically, for some people, it makes them uncomfortable to have somebody maybe perform oral sex, whatever the reason, and we don't judge. We perform those procedures typically under local anesthesia in our office. And I like a very natural look. There's many different looks people achieve. There's a Barbie, there's a hybrid. For me, and look, I always tell patients that I would rather go a more natural where they still have some labia to cover the opening of the vagina. And if at some point that's not enough, we can always go back and reduce. But the one thing we can't do is give back, is what I tell everybody. There's different techniques that everyone uses, and we can have a whole segment on techniques, but this is what I tell everybody. Bottom line, you need to find a surgeon that feels really comfortable operating in a technique or multiple techniques. Because if they're really good, whether it's the wedge, the curved linear resection, it doesn't matter. If they're really good at it and do it often, you're going to minimize your risk potential. Because what you don't want is get a botched labioplasty, which is really difficult to revise and fix afterwards.
Yeah, so well said. And these are the concepts or the take-home messages. Number one is that the reason to do a labioplasty, at least the inner labia, is both cosmetic as well as functional. So like every part of your body, God did not make anything for no reason. So the labia were made in order to close the opening, to prevent desiccation or drying out, to make sure that the area stays lubricated, to prevent from debris, etc. So just removing them all together because they're redundant is a foolish idea. And as a result, naturally, the risk associated with removing something that was designed is that if you remove too much of it, you're screwed. So you want to make sure that the person who does this knows what the hell they're doing. There are hundreds of techniques, and I say hundreds because everyone likes to put their signature on things because it makes them marketable. I do the technique. What the F is that? Well, it's when I take the last segment of it, I twist around. What are you talking about? You're removing excess redundant labia. Got it? Period. And so people love to make, it's not like you're doing brain surgery here. The key is doing it consistently, conservatively, and with, a certain degree of accuracy. So I do agree. I do labioplasties. We're different in that I do them in the operating room because I usually don't do just the labioplasty, whereas you, I'm sure, do hundreds. I do them in conjunction with mommy makeovers. The patients are already asleep. But the fact of the matter is it can be done under local conscious sedation or general anesthesia. And I assure you, and I'm sure you'll echo this, I've never had a patient who wasn't happy. It is incredibly, incredibly powerful.
That's because you're a good surgeon and you know what you're doing. Unfortunately, out in the arena today, and I only specialize in pelvic surgery. I don't do breast, I don't do butts, I don't do anything complicated outside of my field because I know how to take care of complications. Unfortunately, there's a lot of surgeons who, unlike Dr. Rahban or myself, are doing these very infrequently. And when they do them, that's when we see disasters happen. And so please do your homework.
Well, that's the purpose of this show. The purpose of the show, and for those of them that listen on a consistent basis, is I never, ever advocate anything without an extreme amount of due diligence. And labioplasties, as I said, with everything else. I mean, the guy could take off all your labia. And the reason, by the way, that happens not infrequently is the unique aspect of a labia is that of a nipple, of that of foreskin. It's stretchy. So your surgeon doesn't go in there thinking, I got to remove all of it. They put it on tension, they pull it, cut it, and then when they let go of it, it's gone. So that's how the error is made, by the way. And so as Dr. Ghozland mentioned, you can't go back and put anything, it's gone. It's gone forever. So let's shift gears and talk about the outer labia. I'm going to kind of hover over each of these so we can get through all of them. What's your thoughts on the outer labia? What do you do and what do you do it for?
Yeah, so that's a particular area that's actually growing quite a bit. In the sense, when I first was doing this, it was pretty rare that somebody would come in requesting a labia majoroplasty. And we were surgically doing elliptical incisions on the labia majoris, because what happens, as you mentioned earlier, we have fat pads underneath them. And as we age, we start to lose some of that volume, and they start to appear a little saggier, a little more wrinkly. And a lot of times it's bothersome. So we have some tools now to really help aesthetically improve the overall look. So there's 3 approaches that I do. Number 1 is a surgical removal of the excess tissue using 2 elliptical incisions. And I bury the incision in the crease of the labia minora. So really you can barely see any incision. And it's a beautiful surgery. The outcome's fantastic. I use fillers in the area for people who want that immediate, no downtime, kind of improve the volume to the area. And I think that's a really nice procedure. It is transient. You have to come in every year to year and a half to redo it. And believe it or not, probably because of the BBL revolution, we are getting more and more requests for fat transfer to the area to really volumize the area. And so, although that's probably out of the 3 my least favorite approach, it is one that's gaining a lot of popularity. So that's how I approach my labia majora.
Yeah. So basically, the gist of it, it is usually the problem with the outer lips is volume. 9 out of 10 times it's deflated and it's starting to get flat. And of course, naturally, volume is critical in that. However you revolumize it, of course, there's many, many ways to do that. So let's talk about vaginoplasties. And vaginoplasties are essentially when you do work on the vagina itself, the vaginal vault, the inside, the introitus, there's all different terms for it. And I don't actually do any work inside the vagina. I think that's sort of an area where it crosses the limit of my anatomical knowledge as well as my area of expertise. But I know this is an area that you do a lot of work in. And my understanding is that for many people after pregnancy and other reasons, the vaginal vault, that's the space in the vagina, tends to expand. And of course, naturally, a huge component of intimacy is friction. And there's a sort of a loss of that friction in intimacy. And so that creates sort of an issue there. So tell me, if you will, what happens and why we have to even do anything to the vagina and what our options are.
So these are the reasons why people want to come in to tighten their vaginas. Look, you nailed it. Childbirth is a difficult process because you've got this 10-centimeter head coming through the vagina. And oftentimes, as people are in labor for many, many hours and pushing for 2, 3, 4 hours at a time, and it really stretches the pelvic floor muscles, and oftentimes stretches it so much that it causes a separation of the muscles and the inability to really get a good contraction afterwards. And so the typical complaint is my patient comes in and they'll say, Dr. G, I don't get it. When I'm having intercourse, I don't even feel my husband. And I'm afraid he doesn't even feel me either. And it's giving me a much harder time to climax. Is there something you can do? And the answer is absolutely. There's many things we can do. And one of them is fixing the pelvic floor. So now you're moving away from not just an aesthetic procedure, but a truly functional procedure. Because at this point, we are reapproximating the pelvic floor muscles and retightening them so that you can have that squeeze during intercourse. So you can regain that friction that you used to have before having kids.
But is that where the Kegel exercises came in? Are you trying to contract your pelvic floor? Non-surgically, of course. I'm just asking because I'm not a pelvic floor expert, but the idea of contracting your pelvis, is that what that is?
That's absolutely correct. Listen, my personal opinion on Kegel exercises, it's like doing a couple jumping jacks when really you need to be training for a triathlon. It's oftentimes just not enough to reapproximate the muscles. So what we do is and I do this again under local because unlike you, I don't usually combine big procedures with these. And so under local, I slice open and open the vagina, the posterior, the bottom wall of the vagina. And I go about 80% into the canal. It's hard to go the last 20% around the cervix because that's the actual point where a vaginal hysterectomy starts, and you can get into a lot of trouble. And it's actually really dangerous, and there's really no benefit to going that far. So 80% is plenty. People feel amazing results with that. We open the posterior wall of the vagina. We reapproximate the pelvic floor muscles. And I like to do it under local for this reason. As I'm closing, I will put my finger in and have the patient squeeze my finger, and I can assess what kind of degree of reapproximation I'm getting, because that's really important to me. And I want the results to really be as maximum potentially for the patient to feel as many benefits as possible. So we reapproximate the muscles and we trim the excess tissue. And when we close, the diameter of the vagina just really shrinks down and really grips that penis or whatever's going inside to really improve sensation.
Is this procedure, in layman's terms, the vaginal plication? Is that when people say I plicate, or is that just on the outside and there's nothing done to the muscle? Or is this really what plication is about?
Yeah, you nailed it. It's muscle plication, just like you would do on the abdomen. We're doing in the vagina. And then obviously, aesthetically, we're trying to make it as if no surgery was ever performed. And that really, the art of that really comes when you approach the opening of the vagina, which is seeable with the naked eye, and the perineum, which is the space between the lower part of the vagina and the anus. This is a space where a lot of women tear, develop scar tissue, or unfortunately have an episiotomy where they were cut during a delivery and have developed scar tissue. And so it's really important to remove that scar tissue, reapproximate the perineal body. And when we close, we have a tight opening and a tight canal. And that really lends to improve feeling and function, but not just sexually. I mean, you're talking about people who suffer from passing gas during intercourse all the time. That helps. It actually improves fecal bowel movements, because a lot of times if you have what's called a rectocele, which is a herniation between the rectum and into the vagina, which is very common after childbirth, and I would probably say 90% of the time we see that when we open, and we fix that along the way. So that's when I say it's not just an aesthetic, it's a purely functional procedure that will allow them to have smoother bowel movements. And that's a common complaint after childbirth. The surgery is done in the office. The recovery is about 6 weeks. The sutures dissolve in about 4. And people are back to their normal routine 6 to 7 weeks post-surgery.
So let's stop here and do a little recap, because I think this is really, really important. Yeah. This, to me, is the equivalent to an abdominoplasty in so many ways. Because when you give birth, your abdominal muscles are pulled apart. And then people spend months and months and months and months, if not years, trying to do exercises to strengthen it and bring it back. When in reality, nothing is going to bring them back unless the muscles are sewed together. When the muscles are sewed together, you get 2 benefits. You get the aesthetic benefit. Oh my God, my belly doesn't look 5 months pregnant and I'm flat. And you get the significant functional benefits of a lower back pain goes away. I can have a bowel movement because my abdomen contracts, et cetera, et cetera. So this is akin to that in that your vagina stretches, it doesn't function well, and the muscles have been pulled apart. And when you bring the muscles together, you get the aesthetic part, which is it looks prettier, it's smaller, and you get the functional parts, which is now it's sort of, if you will, reapproximated to where it should have been or was. Naturally, the question that one has to discuss is, which I know is a big issue in vaginoplasties, is over-tightening and the ramifications of creating strictures and too small, and then pain with intercourse because now I have now overdone it. So tell me tell me the risk of that and how one mitigates that from happening, other than find a guy that knows what he's doing.
So, I mean, obviously, number one, find the guy or the woman who knows what they're doing. Second, look, that's a great question, because it can happen. It's actually never happened in my practice so far, knock on wood, but I'll tell you why. That's because, one, just like you, Dr. Rahban, you start to learn in plastic surgery or aesthetic surgery or in reconstructive surgery that sometimes more is not always better. And you really want to assess, one, if they have a stable partner, how large is their partner? Because obviously if somebody is really large, I'm going to be a lot more conservative in how I'm tightening, as opposed to the other way.
You have them bring a photo? I mean, let's be honest here.
No, yeah. So let's be honest. So look, I don't typically do that, but if somebody comes in and says, look, I'm a little nervous. My partner is so large that it's scaring me that I don't want to have painful intercourse, but since I've had kids, I just can't feel him like I used to. I will actually give them dilators and tell them to sort of show me the comparison, so that during surgery, I will put the dilator in the vagina as I'm tightening. And that's really the best and most academic kind of way to do it. Second, there is no official classification of how tight one should be. So I typically err on the side of one of my fingers. So my index finger is sort of my guide, and that's my general guide. And that's because, one, I probably have a thicker middle index finger than most guys. And second, I know that during intercourse and arousal, what happens to the vagina, it tends to relax a little bit. So it's a fine line. You want to make it tight enough that they are going to feel that tightness during intercourse when they are feeling aroused, but not too tight. On the flip side, and for another show, in case you guys are ever curious, I did invent a procedure to actually widen the vagina called my intimate renewal procedure. And this is for women who suffer from having too narrow of a canal and can no longer have intercourse. But that's a whole different subject.
That's a whole different ball. Well, we're going to take a break because, shit, I'm even fascinated with this. I didn't know that, finger, I got to look at how big my finger is. And so we're going to take a break. We'll come back and we're going to chat about a couple of other kind of interesting topics. I know people do clitoral hood stuff, but more importantly, Dr. G, we want to talk about the Gspot because I know Gspots are hot topics and they're being milked. Literally, people are making millions of dollars off of G-spots and injections and whatnot. So everyone, you definitely want to stay tuned. We'll be right back with this episode of Plastic Surgery Uncensored. Welcome to the second half of Plastic Surgery Uncensored. I'm your host, Dr. Rady Rahban, and we're going to continue on with my dear friend and colleague, Dr. David Ghozland, as we kind of take a journey down the anatomy and physiology and surgery of female genitalia and sort of all the different ways that we can help and improve the quality of life of women. So we just kind of finished on vaginoplasties, which is tightening of the vagina, but I had a question to ask, which I want to ask before, and I kind of know the answer, but I want to lead you to it. I know that there's two ways to tighten the vaginal vault. Maybe there's more. One of them is surgically by tightening the actual cylinder, aka the plication you discussed. The other I know is you can do it with different lasers. I know that radio frequency, etc. I'm assuming for mild cases to little less than moderate, you use non-surgical, and for severe, you use surgical, but I'm not sure of that. So what's the indications and when do you use, and what are the non-surgical approaches to vaginal tightening?
Oh, I love that question.
You like that? You like that lob?
I love that, Dr. Rahban. All right, listen, there's a lot of different opinions in this field. I'm sure you have your opinions on lasers in your practice. I am not a huge fan of lasers for vaginal tightening surgery, period. I don't care if it's radio frequency, fractional CO2, whatever it is. Look, it doesn't go deep enough to reapproximate, replicate the muscles of the pelvic floor. So what are you really gaining? Look, you're gaining some very, very mild epithelial contraction and remodeling. That's going to help slightly. But if somebody's coming in because they're complaining of not feeling the tightness they used to feel, I will talk them out of the laser or really am transparent with them about the success or what the expectations are with lasers. Don't get me wrong. I have all the lasers, but I use them really for different things. I call them my vaginal health lasers. Lasers are amazing for helping rebalance the pH of a vagina. So women who come in with recurrent infections and are just not having great success with medications, lasers do a great deal of goodness there. They're fantastic for people who suffer from urinary incontinence. So to talk about vaginal tightening, I would say most people who come in for vaginal tightening surgery are complaining of stress incontinence. It's just part of it. If you're going to have damage to the pelvic floor muscles, you're going to have some damage to the entire canal, which includes the mid-urethral area. And so the lasers work great there. The lasers can tighten, and this is what I tell patients. Remember I said I tightened the first 80%? So sometimes if they want, I'll use a laser to help tighten the last 20% that I can't get to surgically, or along the side walls of the vagina. That helps a little bit. I know they're being used and advertised as vaginal tightening surgeries, and they do tighten, but you have to be really transparent with the patients and explain to them it's not a wow factor. So, I mean, basically it's the same crap across the board in all arenas. Listen, lasers are, like all tools, great when they're used for the specific thing they were designed for. If I had a nail and I tried to use a screwdriver, it just sucks. Can I get it in? Maybe if I smash it and do all these, but it's not designed for that. And my biggest problem with lasers today is the following things. Number one, every asshole can get a hold of a laser. So not every asshole can get a hold of a blade and can operate and is willing to take the risks and all the complications. So you have fewer people. Don't get me wrong. There's a lot of assholes with blades,
but you have fewer assholes doing things that they shouldn't be doing when it comes surgically, and way many more doing it when it's non-surgical, and the downsides are less. It's a lot of quackery, and you're selling, snake oil. So how is it that one laser removes a tattoo and the same laser all of a sudden tightens a vagina? And usually surgically related issues that are really bad. You got severe muscle separation in your abdomen, or your face is jowling. It's impossible for a laser to revitalize and rejuvenate the anatomy. So I was just curious. We got that answer, and it makes total sense. And so as always, you just got to make sure you don't expect too much. And if someone's trying to sell you the world with a laser, I would assume that it's all a lie.
Totally true.
Let's shift gears. So let's talk about the clitoral hood, the famous clitoral hood and the clitoris. So my understanding, this is always a good thing because I'm sort of in between the patients and you, and that you're the expert and the patients often don't know much. But my understanding is the clitoral hood is a covering, hence the name the hood, that covers the clitoris. And it sort of is the gatekeeper to prevent you from having orgasms while you're sitting in your car driving and accidentally rub yourself. So, it's here you have this high voltage wire, and you put it encased in some, protective sheath, so to speak. Otherwise, you'd be electrocuting yourself all the time.
You're definitely a car guy.
Yeah. Well, I just like analogies, but it happens to me. So, other than protecting the clitoris, what does the hood do? And so my understanding is, obviously, like all things can overgrow, and then it gets hard for you to have an orgasm because obviously the intent of the clitoris is through friction to help climax and stimulate. And if there's a whole bunch of tissue over it, you can't do that. Is that correct?
You totally nailed it. And just to continue with the car analogy, I use it too. I tell all my patients it's the garage that houses the Ferrari. The problem is, if the garage is too big, the Ferrari is not going to be able to function as well. The problem also is you want to keep balance and symmetry when you're performing labioplasty minoras. So a lot of times, if you're just anything in nature, if you've got broad, enlarged labias, almost guaranteed you have a broad, enlarged clitoral hood. It's just part of it because it looks very symmetrical. So if you're going to do some labia reduction surgery, a lot of times you'll have to do a clitoral hood reduction surgery so that you can keep a very symmetrical appearance. The key is, the clitoral gland and the surrounding tissue is a warehouse of nerves. And so you have to be very careful because that's the part where you can actually, if you're doing it incorrectly, cause sensation issues and terrible pain post-procedure that can become a very chronic issue for the patient. And so you got to know your danger zones, which are obviously the midline, all the way down to the clitoral gland. So when we do clitoral hood reductions, we stay lateral and we do little semi-elliptical incisions on the side of the clitoris in order to help reduce them, or a clitoral lift where sometimes you've got a little bit of a saggy clitoris and you want to sort of make this triangular incision above it and lift up the clitoral hood, which gives it a nice look as well. So I don't know, hopefully that answered your question.
Yeah, of course it answered my question. Basically, you're saying that, the clitoral hood is there to protect the clitoris, and that, when you rejuvenate the aesthetic area there, you got to rejuvenate the entire component. You can't leave somebody with huge labias and a huge hood. You can't just remove the labias and leave the huge hood. Now the hood looks even larger because in proportion, it just looks ridiculous. So the clitoral hood is definitely an area that can be and sometimes is rejuvenated. And as always, you keep hearing this repeating theme is if you overdo it, you do it wrong, you're going to not only not be happy with the way it looks, but in this particular instance, it's more than just aesthetically, whoa, my clitoral hood looks terrible. You're going to have chronic pain related issues. And that in and of itself, like having chronic issues with your nipples, it not only will not help you climax, but it will prevent you from climaxing because you'll be in pain during intercourse because it's right in the middle of the thing. So don't run out and just do this cavalierly. All right, we're going to shift gears to, I don't know. I find this area a little bit kind of hokey pokey. So you've seen me kind of go along the journey with you here, and I'm tracking with you. But this whole Gspot phenomenon and Dr. G, I hope you're not using that as part of your marketing, Dr. G. Come on. I know that there is an area within the vagina that if the pineal gland hits it, it helps stimulate. It's part of the orgasm. But I mean, there are courses and there are millions being made on Gspot enhancement. I mean, people are killing it. Tell me the Gspot, tell me the anatomy, and tell me if it's all hogwash, because I'm going to run out and get my Gspot enhanced tomorrow.
Listen, if you get a Gspot enhancement, call me up, because I'm going to give you a therapist's name, and you need to use her. Look, I think you're right on a lot of points, and yet, you know, it's who knows. I've seen it really help, and I've seen it not help. So let's talk about the anatomy, because I think that's really important. So the Graafian spot, which was really something only discovered in the 1970s, hence the Gspot. So this is a conglomeration of sensory nerves that are located about maybe 1 to 1.5 centimeters behind the mid-urethra, anteriorly, so on top of the vagina. You can feel a thickened little area. Everybody's Gspot is a little bit different. Everybody's reaction to Gspot stimulation is very different. Some people have only clitoral orgasms. Some people you hear have only vaginal orgasms. So that's really important. The idea that people are making millions and millions of dollars, and yes, I'm totally aware of that, obviously, is like anything else in aesthetics. Marketing is a big component of aesthetics, and unfortunately, a lot of people like to promote procedures that have very little data. You know, there was an era in the very beginning when people were using fillers in the area, sometimes even non-dissolvable fillers. I think, thank God, that's very outdated at this point. Today, the current O-shot, which is just another marketing term for PRP therapy in the lateral clitoral hood area and the Gspot, I have seen some good success. Again, very unpredictable. But fun. I mean, you know, listen, PRP is one of these areas that really has very little side effects. And it's one of those win-win procedures where I tell patients we can add it on to your procedure. If it helps, amazing, you won. And the good news is the likelihood of you suffering a complication are almost zero.
So the Gspot, for those people who are men or women who don't know, is an area within your vagina. The anterior means the front end of it, behind your urethra, where there's a collection or increased amount of nerve endings, like your clitoris, where in certain people, when stimulated, helps, enhances, or creates orgasm. It isn't critical in all people, but in some people it is critical. So the objective or the idea was that if we fill some volume in there, it doesn't increase the sensitivity, because you can't increase volume, doesn't increase nerve endings. It brings that nerve ending plate closer, so that when the stimulant, aka the penis or finger, it's easier to get to. Is that the idea?
That's absolutely 100% correct.
So first and foremost, you have to first know, if you're even considering it, if that area within your vagina is critical for you to have an orgasm. In other words, I can't have an orgasm, or my orgasm's 1,000 times better than when that area in the front of my vagina is stimulated either by finger or a penis or whatever. If it is the case, then maybe enhancement of it will then either enhance it or get it back to normal. And the idea initially was that if I add volume to that area, filler, fat, whatever, that area is a larger target, but the nerve endings are unchanged. Is so far is that correct?
That's absolutely correct.
Okay, what percentage of women, statistically, are Gspot orgasmic? In just the clinical data that you, what percentage of women require the Gspot for orgasm? 20%, 10%, 15%, 100, 75%? They got to have that data.
So I would tell you it's lower on the range of maybe 20 to 25%. I wouldn't say it's any higher. Most people do not have vaginal stimulation or heightened sensation just based purely on that one dime size area on the anterior part of your vagina. But for some, it is important and is of value to increase it.
The reason why I'm getting this is I want to help debunk the marketing schemes when it comes to putting volume into we're going to get to PRP in a second. The reason I'm saying that is, if you have never been stimulated by your vagina, it would be amazing to have an enhanced orgasm, right? The average person having sex with their husband, their boyfriend, their wife, their husband or their boyfriend would love to be able to have enhanced orgasm. But if you're never stimulated by there, it just isn't how you get stimulated. You going in and paying $500, $5,000 for a Gspot injection is not going to suddenly make you have an orgasm, because that's not how your body is wired, correct?
Absolutely. That's actually one of my questions. If somebody comes in and says, I've never experienced a vaginal orgasm and I'm really bummed out because we talk about it with my girlfriends and I really want to feel it. Is there anything you can do? Chances are there's nothing I can do to help them.
Well, yeah, that makes sense because that's just not how you're wired. Some people need nipple stimulation. Who knows? That's how you're wired. So I just want people who are listening to understand the verbiage, because my job on this show with your help and other experts is to break the marketing code so that people can navigate it better. So then now we're moving on to a different subject, another concept, which is now we're taking PRP, which we're going to get into a second as to what it is and how it works and whatever. And we're suggesting or saying that if we inject it into that area, AKA the Gspot again, it's now not a volume related issue, but you're saying that it enhances the sensory component. What is it doing, or we think it's doing, or we hope it's doing?
So in sexual medicine, if you can improve blood flow to an area, you're probably going to an area of sensitivity that has a large concentration of sensory nerves. You're probably going to improve sensation on some level. At least that's what I've seen in my practice. So oftentimes we will use PRP in the clitoral area. And since I'm doing it, we also, so this is a really good point. When I do inject it into the Gspot, I'm not just injecting it into the Gspot, I'm actually injecting it into the neck of the bladder in the mid-urethral component, because there's actually good data that shows that PRP injected into that area is another modality of treatment for urinary stress incontinence. And so you're getting sort of a twofer, because when you're doing an O-shot in my practice, you're hopefully helping to improve sensation by improving angiogenesis or blood flow to the area, but you're also helping perhaps some of the symptoms that you're having from urinary stress incontinence. Oftentimes, I will say that I don't just use O-shot by itself, but I use it post-procedure, surgical procedures, because I find, at least in my practice, that it definitely helps with the healing process. And it's something that I like to do oftentimes.
So let's just in general, because I think PRP is super exciting and super experimental. And I use the word experimental loosely. I don't think we're experimenting on people like guinea pigs. But like many parts of medicine, you're going to give someone chemo. It goes through some really rigorous trials before you give a person chemo. As a matter of fact, we probably could give the person chemo 2 or 3 stages earlier, but because we're such a conscientious medical community, we don't give people chemo, even though it could have saved them, because it could kill them. PRP or other areas where it's not going to kill them, it may not benefit them the way we want, but it's not going to kill them, there's a much looser rein. The problem that I have in general is the claims that are being made by orthopedists, urologists, plastic surgeons, dermatologists, is we take this golden stuff and then we inject it in you and all things go away. And for the listener, they need to understand that that's hogwash. First of all, what is PRP? What does it stand for?
It stands for platelet-rich plasma.
Right. So essentially, you're taking people's blood, you're spinning it, you're concentrating it, and you're taking a high concentration of their plasma with platelets in it, right? And then the idea, and tell me you're understanding it, is there's a lot of other goodies in there. And by goodies, we're talking about things that are in your blood circulating that do things that we like growth factors, bring in blood vessels and things like that. The thing is that the science is still kind of very ambiguous. There's a lot to be learned. And right now what we're doing is like you and like the orthopedist who injected into knees and like the urologist who injected into bladders and like the dermatologist who injected in the skin. And I mean, it's ubiquitous in every area. We know there's something in there in this PRP. We don't know what it is. We don't know exactly how it works, but F it. I'm going to inject it because clinically we've seen good things, because we've seen people's scar tissue get better. We've seen more blood supply. So I just want people to understand the level of science that we have and where we're at. Should we do it? My wife is thinking of getting PRP injected in her spine. She's had 4 spine surgeries. She's got crippling pain. You better damn well bet we're going to inject PRP. But we're going knowing that it's there's a lot of hope involved. If it's your primary source of treatment, I would caution people to put all their eggs in that basket. We're not there yet. I think in 10 years, we, the medical community, will isolate the specifics. Oh, like it's such and such protein. It's such and such growth factor. And then we'll get really good science. Right now, we're basically spinning it and injecting the whole shebang, and we see good things. I just don't think, and I think the way you do it is absolutely right. You're like saying, hey, listen, I don't see a lot of downsides. I've seen clinically some upsides. I don't just inject it in area. I inject it in a global area, and I seem to, in addition to my other things, which I know work, I see that it's kind of made it a little bit better. And I think the way you phrase it is really what it's about.
Yeah, and I think it goes all back to marketing, Rady. I have patients who come in, I'm sure as you do, who come in for a consultation. They're here for an O shot. They want to see me because I perform the O shot. So it's always important to really assess a good history and what their realistic expectations are from the O shot. And when you hear them talk, you listen to the fact that they have read so much false information on what's going to happen with the O shot that you have to bring them back down to reality, because like you said, we don't really know. It's so individual how everybody's going to respond to it. And also I never use it to specifically treat urinary incontinence. As I mentioned, it helps, but it's definitely not my only choice of urinary incontinence and would never be my primary choice. But it may be a nice little icing on the cake when I'm doing surgery for urinary incontinence. Why not?
Everything is about transparency and phrasing it and educating people. It's like, hey, listen, I'm not sure. We're still in the early phases of understanding this, but I've seen some benefit. Then the patient really knows what they're dealing with. And that's just medicine. Medicine, it's called the practice of medicine, right?
But not everybody practices that way. That's the problem with lasers. When I have patients who come in and say, I don't understand. I'm so upset. I just paid $3,000 for a Mona Lisa with my chiropractor and it didn't do anything. And they come in and they have urinary incontinence. And I say, look, first of all, the fact that a chiropractor is doing your urinary incontinence laser is really disheartening, because when I'm doing lasers, it's not just about going in a 360 circle. I'm focusing on certain anatomical areas that I know they're deficient in, number one. And number two, I know perfectly well that's not going to help them because they got the lasers for the wrong reason. It was just an upsell.
Yeah. Listen, all this is incredibly fascinating. For me personally, I am beyond frustrated with all the BS that's out there in general. I'm vocal and I'm opinionated and I'm over it. And so that's what this podcast is for. Podcast is so that you and I and me and other guests, or me, myself, can help really break this crap down for people so that they can make good choices. If you're going to a chiropractor for anything vaginal, you're an idiot. End of discussion. You're not helpable. But for people who are genuinely interested in learning and they want to figure out, God, I hear all these things, all these people, this is one way, and you do it every day in your practice. And at the end of the day, as a physician, you pick your path and you decide how you want to go about doing it. For me, this is my path. You do an honest job, and enough of us do that, patients will be well.
Well, can I say one thing then?
No.
Before we get off the show?
I'm just messing with you. Yeah.
Listen, I know you are. For anyone who's interested in learning more about cosmetic gynecology, I actually have a published book that's out there. You can find it on Amazon. It's called Everything You Need to Know About Cosmetic Gynecology. And I have spent the entire pandemic lockdown working on this book. It's basically a conglomeration of every procedure done in the pelvic area. Talks about risks, benefits, protocols, pre-post-op instructions, and it's something that I think would be wise to get before doing surgery or doing consultations.
I love it. Tell me it again so we can plug it. What was it called?
It's called Everything You Wanted to Know About Cosmetic Gynecology.
Got it. Everything You Need to Know About Cosmetic Gynecology. Dr. David Ghozland, and that is Ghozland. He's the man.
Right. Dr. G.
Dr. G. We appreciate it, and we're well overdue for a dinner with the missus.
You got it. Thank you so much, Rady.
Thank you for listening to Plastic Surgery Uncensored with Dr. Rady Rahban. We would love your feedback. If you enjoyed this episode, or if you find our podcast helpful, tell us why. Leave us a review and make sure you subscribe on your favorite podcast platform. If you have a topic you would like for us to discuss in an upcoming episode, please reach out to us on Instagram at Dr. Rady Rahban, on Facebook at Rady Rahban, or at RadyRahban.com.